ازي حضراتكم جميعا، اهلا بكم. انا احمد القيعي، والنهارده ان شاء الله هتكون اول ام دي تي ميتنج فينا باذن الله. احنا في انتظار الدكاتره دكتور نتيشن ودكتور دينش تو جوين اس ان شاء الله. هو النهارده ان شاء الله اليوم هيمشي ازاي؟ احنا اول حاجه دكتور احمد نصار هيعرض اول بيشنت، وبعدين دكتوره شيماء هتعرض البيشنت الثاني. بعد كل يعني برزنتيشن الدكاتره دكتور دينش ودكتور نوتيشن الاثنين هيكومنتوا، وبعدين دكتور علاء رشاد ان شاء الله. ولو اي حد من الدكاتره عنده اي اسئله هستاذنكم بس يحطها على الجروب وانا هقراها ليهم وان شاء الله نبدا. Okay, Dr. Natation is here, right? Okay, we are waiting for Dr. Danish.
Yeah, I'm here, and Arun and Dr.
Okay. So, okay. So, good evening, everyone, and welcome to our first MDT meeting in the run-up to the Indo Egyptian SEEG week. It is my very great pleasure to introduce and thank our two guest faculty who make this program possible. The three faculty, of course. So first is Professor Danish Nayak, a world-class epileptologist whose team has performed hundreds of SEEG cases and who has been mentoring our group from the start. And with him, of course, Professor Natation, an experienced functional neurosurgeon, and who has visited Egypt twice. And through his technical leadership, who will guide our implantation and intraoperative work. And also Dr. Arun, who is an epileptologist, also from India. So we welcome three of you, and we are deeply grateful for all of you for traveling this long distance in November, and for sharing your time and expertise, and of course for committing to this live SEEG implantation in Cairo. Your mentorship is the most important factor in safely launching SEEG in Egypt, and of course making our training and our national teams possible. So thank you, professors, for your partnership. And now we will start with the first case. Okay. So now we will present the first case by Dr. Ahmad Nassar. He will present the case presentation, a short video EEG review, and a few quick poll questions. Then we'll have the expert commentary from Dr. Danish and Dr. Natation and Dr. Arun, followed by comments also from Dr. Alaa Rashad and questions from the audience. Please keep the comments brief. We will circulate the SEEG plan later through email to all of our participants. Okay. Dr. Ahmad Nassar, are you ready?
السلام عليكم.
وعليكم السلام ورحمة الله.
وعليكم السلام ورحمة الله وبركاته.
ازيكم، ايه الاخبار؟ يا رب تكونوا بخير. انا عملت شير السكرين كده، السكرين واضحه؟
واضحة.
اوكي، ويل ستارت. Good afternoon. I am Dr. Ahmad Nassar. I will present Lara. So Lara is a 5 years old girl with seizure onset at age of 2. Normal development, and she is right-handed. We have 3 home videos that show typical events, unfortunately better than scalp EEG. Initially, she presents with a special ictal semiology, as we will see, called gender. Then only يعني Chabot was with left dystonic butchering of upper limb, right upper limb. She was sleeping. This event occurred out of sleep. As we can see, the Chabot, meaning butchering of both upper and lower lips. Then we can repeat the video again. You can see Chabot now with left dystonic butchering in left upper limb, followed by bilateral blinking, more prominent on the right side. This is the second home video. Chabot syndrome. Left upper limb dystonia. The mother was able to record these videos because she gets multiple brief nocturnal seizures. And this is the third home video. In this video, you can really appreciate the prominent right side blinking. So we have three home videos starting all out of sleep with Chabot gendarme, then left upper limb dystonic butchering with bilateral blinking more prominent on the right side. This is video showing the Chabot, what's meaning symmetrical contraction of both lower limbs. So Dr. Ahmad Al-Koyai, the first question.
Okay, I sent in the first poll question. The question is, what is the most likely symptomatogenic zone for LARA semiology based on the video EEGs we have seen? So we see chapeau de gendarme with left dystonia in the left upper limb. Please vote on the Slido you have seen on the Zoom link so we can proceed. لو دكاترة في طلع زي question كده اللي هو بتاع سلايدو، استاذن حضراتكم لو تجاوبوا عن طريق.
واحنا كان عندنا السيميولوجي يا دكاتره خلاص الشابو والليفت ابر لمب ديستونيا، فيعني احنا محتاجين من السيميولوجي ده يعني للاسف ان الاكتال اي جي هنشوفه بعد السؤال ده. الاكتال اي جي بتاعنا مش لوكالايزنج ولا لاتراليزنج كاي جي اكتال، مفيش اي باترن ديفينيت اكتال اي جي. فيعني احنا كنا محتاجين من السيميولوجي ده نحاول نلاترلايز ونلوكالايز. هل هنقدر نلوكالايز ونلاترلايز من الهوم فيديوز او الفيديوز اللي اتصورت على الفيديو اي جي وزاويه اكتال اي جي ولا لا؟ في ناس بس بتقول مش شايفه البول. لو يعني في الزوم على ايدنا اليمين كده هتلاقي فيها السلايد والاوبن والاجنور. لو اتكينا اوبن السؤال هيتفتح يعني الناس تبص عليه.
Okay, so I will now end the vote. The question was, what is the most likely symptomatic zone for large neurology? We have for left mesial frontal 24%, for right mesial frontal 67%, right temporal 9%, and no left frontal.
يعني الشابوت ممكن نعمل اناليسيس بس كده للانسرز دي. هو الشابوت سيميولوجي ده يعني بيهلب اس تو لوكالايز ان ميزيال فرونتال اوريجين. الشابو دايما زي ما نشوف في البيبر اللي هنحطها بتاع بونيني، خلاص هو البونيني عامل كلاسيفيكيشن مقسمين الفرونتال سيميولوجي 4 جروبس، بونيني 1 وبونيني 2 وبونيني 3 وبونيني 4. فالشابو ده لوكالايز فور فرونتال سيميولوجي بونيني جروب 2 او بونيني 2. الليفت ابر ليمب ديستونيا ده بيلاترالايز تو ذا رايت سايد، كونترالاترال ديستونيا بتبقى كونترالاترال للليجن. فاحنا عندنا دلوقتي الشابو سيميولوجي يبقى اصله لوكالايز ان اميزيال فرونتال اند الابر ليمب ديستونيا ابسيلاترال، والرايت بلينكينج لاترالايز تو ذا رايت سايد بيبقى ابسيلاترال، البلينكينج بيبقى ابسيلاترال للليجن. سو وي ار لوكينج فور رايت ميزيال فرونتال ليجن. ده تقريبا مع الاغلبيه بتاعهم. زي ما قلنا كده الفيديو اي جي شو ما كانش فيه نو انتر اكتال ديسشارج اند نو اكتال باترن ريكوردد ويز الفيديو اي جي. ده السليب وده الاويكننج، الباك جراوند كانت كويسه، نو انتر اكتال ديسشارجز. دي الفيديو ريكوردد بالفيديو اي جي روز نو يعني زي روز نو انتر اكتال ديسشارجز. لو بصينا دلوقتي هنلاقي يعني الشابو بدأ يعني حاجه بسيطه كده برضو. الفيديوهات اللي مصوره بالفيديو اي جي الليفت هاند كانت هيدن شويه فما كانتش باينه، فالديستونيا مش واضحه قوي، والشابو جه في اول الفيديو كده حاجه بسيطه. كانش في اي اكتال باترن خالص. الحقيقه بعد النوبه بيحصل بايلاترال مايكلونيك جيركس كده، هي اللي بيبقى معاها اكتال اي جي. سكند فيديو اي جي صورنا طبعا فيديوهات كتير بس ما فيش ولا فيديو معاه اي اكتال باترن. وهي صورت طبعا يعني كذا يوم عشان نجيب هوم فيديوز فيديوهات كتير نشوف فيه اكتال باترن معاه ولا لا. الفيديوهات كلها معهاش اي اكتال باترن، وفي نفس الوقت برضه صورت كذا ساعه مفيش اي انتر اكتال ديسشارج خالص. يبقى الكونكلوجن بتاع الاي جي شو نو انتر اكتال ديسشارج، ما كانش فيه اكتال باترن ريكوردد ويز الاكتال ايفنتس اللي اتصورت. السؤال الثاني برضو دكتور احمد كده ممكن يحطه لنا، هل does يعني ان النيجاتيف اي جي doesn't rule out epilepsy؟ يعني البيشنت ده كده ما فيش اكتال اي جي ولا انتر اكتال اي جي، هل ده يعني يرول اوت ان البيشنت ده ابيليبتيك ولا هنشوف بقى الفوتنج بتاع الناس.
أنا I publish the vote again on Slido. Please vote. We have 100% response on this question. So yes, normal EEG or negative EEG does not exclude epilepsy or seizures.
Okay. As we know, negative scalp EEG doesn't rule out epilepsy. Deep mesial frontal onsets are often invisible on scalp EEG. دايما الميزيال والديب البيزال lesions دايما تبقى negative on السكالب EEG. Negative EEG in deep onset context can be a positive localizer because it suggested deep or midline onsets. فالاي جي ده معناه ان هو نيجاتيف، ده معناه ان هو بيساعدنا او بيكونفيرم ان احنا عندنا حاجه ميزيال او حاجه ديب ليجن.
دكتور احمد معلش ممكن can you please keep the discussion in English?
Okay. This is Bonini classification. The Bonini subgroup الفرونتال semiology into four groups: Bonini type 1 type 2 type 3 type 4. As you can see, الشابو is in Bonini type 2. So شابو is a frontal semiology and can be localized in شابو in Bonini type 2. We did 1.5 Tesla MRI, initially reported negative. So 3 Tesla epilepsy protocol showed small right mesial frontal lesions consistent with FCD, as you can see. This is
Can
our
we just
lesion.
can we just have the video of the semiology replayed again?
Okay.
Basically, due to some technical problems, Dinesh sir could not join early. So if you can replay the videos, then we can
Okay,
actually
Dr.
have a
Nadesh.
discussion on the semiology. Because we don't have anything from the EEG, we can have a discussion on the semiology before we can go to the imaging.
Okay, Dr. Nadesh. This is the home videos, and we saw that semiology is more prominent in home videos. Started out of sleep with Chabot and left upper limb dystonic butchering. Then bilateral blinking, more prominent on the right side. This is the second home video. She recorded multiple brief nocturnal seizures. This video showing the bilateral blinking, more prominent on the right side. You want to see this video's documentation? Video recorded on EEG.
Yes, please repeat them.
Yeah, I mean, we just want the description of the semiology, and based on the semiology, the areas they would correspond to, so that we can have the anatomo electro clinical localization. Here we don't have any electrical data, right? Because no IDs and no ictal EEG changes. So that now we need to sort of look at from the semiology where probably this seizure could be originating and where it is spreading.
ماشي يا دكتور أحمد، ممكن تكمل على الجزء بتاع الإيمجينج. So basically, regarding the semiology, we have a Chabot de gendarme that is occurring out of sleep, nocturnal, multiple times, with left dystonia, followed by bilateral blinking that is more prominent on the right side, but the EEG is silent, whether interictal or ictal.
So according to imaging, first we did MRI epilepsy protocol 1.5 Tesla that was reported negative, and then we did 3 Tesla epilepsy protocol, showed small right mesial frontal lesion. If you can see this is our lesion with slight transmental sign. We also did a bit that confirmed our lesion. This is a hypometabolic area in the bit right mesial frontal. Video for Dr. Michael showing 3 Tesla lesion and the hypometabolic area in the bit. If Dr. Michael is present, he can comment on the imaging. Dr. Michael?
Unfortunately, I think Dr. Michael is not available. The thing that Dr. Michael was a little bit skeptical because of the lesion. Can you please show the MRI again, Ahmed? So
I think this is
yes.
the most
He was,
visible one.
yeah, regarding the transmantle sign, he was a little bit reluctant because he thought this could, one of the differentials is this could be a vessel. But because of the semiology and the very localizing PET, he became more convinced. Okay, so go on, please.
Our irritative zone, there is no interictal discharges, ictal onset zone, no definite ictal EEG correlate with our seizures, symptomatologic zone, right mesial frontal, Bonini type 2, and the functional deficit zone, as we see, bit hypometabolic area in right mesial frontal, eloquent cortex, motor area, right SMA, epileptogenic lesion, right mesial frontal FCD, our hypothesis right mesial frontal. So our question now, if we can proceed to direct lesionectomy with intraoperative motor mapping and ECOG, or to perform SEEG first to define extent and perform motor mapping. And thank you.
Thank you, Dr. Ahmed Nassar. Now I invite Dr. Danish to please comment on this case. Dr. Danish?
Yeah, I think there's this thing technical glitch again. Can Dr. Arun, can you give your opinion on the semiology? Yeah. So meanwhile, we'll check with Dr. Dinesh.
Yeah, Ahmad, it's a nice case explaining the Bonini type 2. Yeah, from the history wise also, child with no antecedent illness or no developmental delay. She had sudden onset flurry of seizures, nocturnal. So it point towards underlying structural substrate. And also we know that in a frontal lobe epilepsy, since the surface area of frontal lobe is more, so we generally under deep inside like a mesial structures, we don't get intraictal discharges, and even the ictal correlate also we don't get it usually. And you guys already nicely explained everything, all the reasons, and even the semiology. You guys have uh, uh, illustrated very well, like Chapu, and also the dystonic posturing. Everything you guys have told in detail, and about the Bonini type 2 classification. Also, you have showed the classical paper, and the flowchart has been explained everything. And even the MRI and MRI, we need to look because the limited images were available in the slides. PET was conclusive. So MRI, even the radiologist, you guys said like he's having a little bit of doubt. But we can say from this everything, most of the things are correlating, and this can be a direct. In my opinion, this can be a direct case with direct lesionectomy. under ECOG guidance, instead of going for SEG and um, then motor mapping. This is a safe zone to resect, and Dr. Natison will comment on that also, since he is the surgeon.
Thank you so much, Dr. Arun. Thank you so much.
Yeah, so when it comes to the resection part, see what we see here is that definitely in the FCD, in the MRI, there's a doubt that there is an FCD is there. Okay, but then when we are doing MELD processing, I think the lesion extension is quite posterior also. Okay, so what we initially saw on the MRI is in the lesion is along the anterior cingulate, just superior to the genu. But then on the processing, it was showing to be extending all the way up to the SMA. Okay, so with this in mind, definitely there are always two options. One is directly to go and resect with the eco guidance. That is like, because it's on the right side, we might have that liberty to go forward and resect it. And the other option is when we feel it's like to be very exact or very is not that always necessary when we are doing it on the right side. Okay, we can actually go ahead and directly resect it is what would be my my understanding of this. As that's what I think Dr. Arun also had opined on. Dr. Ahmed, what do you think?
Yes, but this case was initially for us, it was like an MRI negative because we did a 1.5 Tesla initially. Then also usually we like it when the radiologist finds the lesion before we point we point it to him. But this is always the case.
Ahmed, Dinesh sir has joined. Hello, sir. Yes, sir.
Hello, Dr. Danish.
Hello. Hi.
Hi, Dr. Danish. It's very nice to have you,
Dr.
sir.
Ahmed, how are you? Sorry, I was.
It's a pleasure.
Sometimes I was not in the picture, so I don't know. Unfortunately, I missed almost everything about this patient, so I can't really comment. But yes, I believe there's a lesion.
Would you like for us to be brief?
No. I was there up to the chapeau, and
Yes,
I said there's a left upper limb dystonia. Is it? That's what I was.
Correct. But the EEG interictal and ictal is negative, and we have a lesion in the right mesial frontal lesion with concordant hypometabolic PET.
Right mesial frontal. Yeah, I can see the mesial frontal hypometabolism. Yeah, correct. True.
So
yes. Yeah, can you just show where the MRI?
Can you make the image full screen and then show us the lesion on the MRI, please?
Okay.
Just for a minute. Yeah. Is it very clear-cut lesion or what?
Sorry?
Okay. Yeah. Okay. Now, can you just please run it? I'm sorry, I'm making you to duplicate your work.
Are you showing it from the DICOM viewer? Yeah.
Yes.
Yeah. From the DICOM viewer. Where exactly can you just point out?
شاور عليها نص.
حاضر اليوم بس كده.
Yes.
With the marker, can you please show it?
Yeah, which
With
is the area
the
of
cursor. Can you please point out with the cursor, please?
No, just with this thing only. Yeah. I just point out where exactly.
This is the most visible cut.
No, can you go anteriorly a little bit, please?
Bit loud.
I
Can you keep going anteriorly, please?
Yes.
Yeah, this is the area, sir. Like on the right side. Can you put the cursor there?
this one.
Yeah, just keep
This?
going. Yes, sir.
Okay.
Yes.
Yeah, and come a little more anterior. And
Can
the
you
thing
put
is,
it
it was
on?
not very clearly evident, sir. Like can you come some more anterior,
Yeah,
please?
looks
Keep coming a little more anterior. Yeah. So this area, stop, please, stop.
No. More, yeah, a little more back.
Little behind. Little behind, please.
One.
One more slice behind. Yeah, this slice also looks the little. This one, sir. Like
Yeah.
the slice and the one behind.
Yeah, but that's on coronal. But can you just show it on 3?
Axial.
No, you can put it on 3D. I mean, all the 3
Yes, sir.
axials.
That MP3. MPR, can you put it?
Sir, I
No.
think
Where
if
you see all the simultaneously, where you can see the 3. Did you do that?
Yeah.
Yeah. Nassar, can you
see
please
on
share
sagittal
the
and
video?
axial and sagittal and see the posterior extent and all that?
Yes.
Yeah. Okay. Now you can put it on the area of interest there.
Sir, I think it will be useful if you see the hypometabolic co-registered with the MRI first. It will help us localize where the lesion is. Nassar, can you please?
No, now that we are seeing this, we can just compare both on the coronal and on the sag and also axial. And then we can always go back to the PET and see what we are seeing that area like.
Yeah, that's the place. Okay.
On the sag, can we please zoom in?
Sag.
Put the cursor there, and can you please zoom in the sag? And then we can slide up and down in sag.
Coronal?
Sagittal.
Sagittal?
Yeah. Yeah, there seems to be an abnormality there. Yeah. True. Okay. Yeah, I mean it is seen there. Yeah. Yeah.
And also the sag.
Your voice is not very clear.
Yes.
Dr. Danish, I think also if you see the PET.
Okay. You please show the PET.
Nassar, real video.
You had kindly sent that the presentation. Now I just see the PET. Yeah, I have the PET in front of me. Yeah, that shows a clear abnormality there. No,
This video, Dr.
hypometabolism. It's going to come now. Yeah, that's the place. Yeah, I agree. Where exactly is that? That corresponds to that same. It's not exactly corresponding to that particular region that you showed on the MR. This is a little more posterior. No, that's what.
Yes, sir. So that 2 areas of abnormality when we see, sir, one based on the PET when we see is quite posterior, and that area corresponds to that where PET, the MELD shows. The MELD also shows that posterior. Just below the SMA and just anterior to the SMA. So that the MELD is pointing out to.
That's what. So there is a discordance between what you found on the MR on the structural imaging and what you see on the PET. It is not corresponding actually. This is if you have to look at the, can you just go very anterior where on the PET? Anterior, very anterior. That is the abnormality. That is very clear. I agree fully with that. That particular this thing is not in relation to the structural MR abnormality that we just now saw. So there is
Yes,
a
sir. It's posterior and at the level
so
of
that's
motor
why I'm
and SME,
asking,
sir.
can you just take this PET more anterior and let's see in the region where we suspected
Yeah.
the abnormality. Can you go more anterior on the PET?
Dr. Ahmed, can you go anteriorly in the
This is
Very
PET
anterior
and
on the
this is
towards
PET.
the area?
it's not actually Nasser. Can you please play the video? This is a video, sir. It's not the actual PET.
This is a, what is it?
This is a video recorded while we were playing the co-registered PET. It's not the actual source.
Okay. So this
Unfortunately,
is the
my
maximum you
people,
have, isn't it? But can you kindly again play it, please, from the beginning? Can you just yeah, you just play it from yeah, that's pretty anterior. And I mean, the MR abnormality would have been somewhere in that region, what you're seeing at the moment, but nothing much is seen on the PET where we thought the MR abnormality was. On the other hand, the PET abnormality is clearly there, and that's quite behind actually. And that particular, yes, but that particular thing on the MR doesn't look very impressive. You get the point? No, that's what I'm trying to. It really doesn't. The MR abnormality on this particular cut, which shows the PET abnormality, does not look impressive. The MR doesn't look at that point where there's a functional, hypometabolism. The MR abnormality is not very significant. Where we suspected the MR abnormality to be, the PET is insignificant. So there is a PET MR, in my opinion, there is a PET MR discordance. The laterality is good, but there's a discordance between what we thought was the MR abnormality and what we clearly see as the PET abnormality. There is no doubt about that.
Yes.
Yeah, that is very convincing. The PET abnormality is very, very convincing. But then that is actually quite posterior to the place where you actually showed initially, where we thought was the MR abnormality. So how will you reconcile with these two? How will you reconcile with these two discordant information that you have?
So we have one more information from MELD also we have.
Okay, then
Dr. Ahmed, can you please share MELD?
Yeah, so if there is a MELD, we would like to see the MELD.
The MELD is actually 1 second, please. I'll try to.
Yeah, please.
May I have a question, please?
So Shema, Dr. Shema is also one of our team, and she's asking if she can ask a question.
Oh, yeah. I mean, absolutely.
Good evening, Dr. Natation, and good evening, Dr. Nitish. Good evening, everyone. Thank you for this great opportunity and this great discussion. I actually want to have more illustration from Dr. Danish about his interpretation of the PET MRI findings. As you know, the PET is a CT, so it doesn't show the depth or the anteroposterior gradient or the full thickness of the lesion that is shown in the MRI. As I can, in my mind, I think that the PET hypometabolism, when it is co-registered to the suspected area of the MRI to the lesion, where should the lesion be in the MRI, can increase the yield of the surgical resection and get a better prognosis after resection. But here, if I get it, I'm not sure I got Dr. Danish right or not. So I need more illustration
make sure that that is showing exactly which area, which is the structure behind the functional deficit. So that's something that we have to do, and I think you have done it in this case. The problem, what I find, I just came in a little late into this discussion. I had come a little earlier, but then I lost out in between. And when we were discussing the MR, the structural MR alone, initially, what we thought as the mesial, rather the anterior cingulate lesion, seemed to be quite anterior, very anterior. But when we are seeing the PET, which shows a very discrete focal hypometabolism in the mesial frontal, that is quite more posterior to what we saw on the structural MRI. So in that sense, there is a discordance. Now, when you see the structure behind this hypometabolism, I can't see much of an MR change. That is my bit of a worry. You got what I'm trying to
Yeah, I got you completely, but I wanted to ask
Yeah.
if sometimes as we all know that the FCD could be the FCD type 2, particularly type 2 with the very nice transmental sign, could have some abnormalities or some extensions even beyond what we can see in the structural MRI, like you just was explaining, sir. Because the MRI, it's not the full 3D. It doesn't
Right.
show the full 3D dimensions, and that's
Yeah.
the merit of the intraoperative monitoring using ECOG or even with depth electrodes. So, yeah, this slide, could this be actually described as a discordance, or it's a little bit more of anteroposterior gradient?
A very good point. It is not what is that? A clinico-radiological discordance. No, it is not a clinico-radiological discordance, but I mean, maybe the PET abnormality is little more. Normally, the PET abnormality is more widespread than what the MRI abnormality is, generally speaking.
Yes.
It also shows the network.
Yes.
So the functional deficit is usually more than what the structural would show. Here, it seems to be the other way around, isn't it? I mean, you see a structural lesion which is a little more different from the PET abnormality, which seems to be very, very discrete. It's a very discrete abnormality.
Yeah.
So, and if you look at the seizure type, which is a very focal, very restricted network, you would expect a small lesion, not a very large one. So that is also there. It's just counterintuitive to think that, yeah, this is being produced by a very tiny but an abnormal area. And from that point of view, I would plumb for the PET, because the PET shows a discrete hypometabolism, and quite likely that is the place where it seems to be quite discrete and quite small, and that quite goes well with the clinical abnormality, which is a very focal, very stereotyped, the same kind of a network. He just has some chapeau and then with some focal dystonia of the left hand, isn't it? That's what it is, and some ipsilateral eye blinking. So
Yes,
ipsilateral eye blinking and contralateral dystonia and bilateral tonic downturn of the lip. So that's what it is. So there is an elementary motor, and this is a more premotor and posterior prefrontal. That is the That is the region where the posterior prefrontal is the one that gives you the chapeau, and the premotor gives you the lateralized, the dystonic hand. And the eye blinking, obviously, I mean, that can happen, ipsilaterally on any hemisphere. So I think that's what it is. So I don't know whether I can proceed directly with surgery. You can, but I am still a bit worried about what is the extent of the surgery, how much.
So if we had to implant, can we say we have a lateralization that only right side will implant, but then we'll have to explore the areas of one will be where we got from the PET, and then those.
I think we should spend a little time on those abnormalities, and if we are really convinced, I think you can do without this thing now. Yeah, I think that's what we should be doing. I think what we'll do is we'll have a even closer look at this the MR
Yes, yes. So,
and the
Yes, sir.
and you were just
Yes.
showing the meld, isn't it? You just showed Dr. Ahmed, you were just showing the meld. Can we just have a look at the meld?
the left side, but I have one comment because Dr. Michael, our neuroradiologist, is not here. So basically, what he saw in this exact, screenshot you can see on the presentation now, there's a transmantle sign, but his only worry whether this transmantle could be a vessel. So he cannot really appreciate any thickening of the cortex or
Yeah,
in the cortex. He can only see this very subtle transmantle sign.
I can see it. I can see it.
And this is actually the concordant hypometabolic area in the PET.
Sorry, that corresponds to that, is it?
Exactly this one, yes.
Yeah, because you can see
Yeah.
because that you can see the ventricle there. You can see the ventricle. So in that MR abnormality, in the PET abnormality, that is the place where this is actually.
Yes.
And you can actually see the transman. Yeah, I can see the tail actually. It is just going down nicely actually, and there is a slightly more, more hyper intense than the. How does it look on a T1? Because that would be nice. I mean, you could. Because if this is correct, if you're confirming it on T1, if there is a slightly there's a slight the
Unfortunately, we could not find any
you
abnormality.
could not you can, if you do some windowing and say brighten it a bit and all that, I think you may be able to where the ventricle just begins to come into view. That's the place where it showed. Okay, now you're coming almost to that. If you brighten it a bit, no more anti. Yeah. Keep going. I think that's not the place. That's not yet the place.
يطلع قدام.
Is
Posterior
that the
or
place? I think this is not the. Can you make some? Can you brighten up this to increase the gray white, the contrast?
We can have both
alter
flare and T1 in one slide if this is possible.
some of the. The coronal. Yeah.
هم الاثنين في كورونا.
Yeah. Okay. And let's come to the coronal of.
هات كورونا.
We'll first show the transmantle first on the flare, and not that. So that was a little different.
I think
Where is the
this is
transferal?
frontal.
Yeah, it was a little different. I think it's just a slight change and see. I can't see the transmantle at the moment. It was not the same.
I think it's because of the
No. Now, yeah, now keep moving. At one point we did see you stopped it.
This
I think can be appreciated here.
I think this is the most obvious one.
Yeah.
profile.
The next one, I don't think this is the one, because you will see the partial voluming in that particular cut. You'll see the partial voluming of that the next gyrus. So that's see the transmantle. One more cut, I think. You're somewhere close by, but not exactly. No. Now the windowing is good. Now we'll have to hunt for it.
For the participants, see, this is how usually we do the real MDT, where we as a team, we go through the image and look for the lesion and then have a discussion. It would have been easier if we had actually already identified and had the discussion showing that this is the lesion, this is what we want to do. But then we wanted you to get the feel of the real, how the discussions happen, the challenges, what an epilepsy surgery unit faces when they make a decision. So that's why we wanted to be real organic.
What I see, the transmental is going lateral in this coronal flare, not going medial, just a little bit, only cut, one cut only.
Anterior or posterior?
Posterior. Again. So the other side, sorry, the other side. But little bit, because the cuts just now only. No, go back. I think it's going lateral. So I think this patient is, I saw it is going lateral, not medial. Only one cut. Anterior posterior like this. Very faint, I think.
Yeah. We're very short on time because we still have to.
I know. This is. I think also the PET scan is in a gyrus, not that we suspect in MRI. Different places, I think. And we have also negative EEG. So yeah, look like this, like this. Stop.
Okay.
Goes as a side. One cut anterior, one cut posterior. Look, it's going lateral. Not on the same. Yes, this one. Yes, this one. If you follow it on the sequence, you will see it going down because they are not on the same angle with the cuts.
Okay, so I think we already we are a little bit late in time.
يا دكتور كانت صعبه قوي، انا مش عارفه ايه اللي جرالها. حركتها كتير قوي وبتشد بقى صعبه من الاول كتير. انا مش عارفه فيها ايه، يعني هي حتى ما كانتش كده. بتكون حاجه عملها قرنها مخ تاني، كنت فلاها حاجه، فانا مش عارفه ايه.
So, Dr. Danish, if you don't
Yeah.
mind, we can have a further discussion about this patient
Sure.
later on.
Sure. Absolutely. I think this needs more in-depth understanding of the relationship between all these three things. I think there's some discordance and we have to answer that. Yeah. Thank you.
Yes, Dr. Michael, the neuroradiologist, will be there, so we will have more.
Yeah. Sure.
So,
Yeah.
thank you, Dr. Ahmad Nassar. Thank you, Dr. Danish and Dr. Natation.
Thank you, Danish presentation.
Now
Thank
we
you.
will move to the
Thank you.
second by Dr. Shaban. She will present the case, and we will also have a discussion. Thank you. Dr. Shaban.
السلام عليكم. إن شاء الله يعني hopefully this the second case would be easier to go. Hopefully, I don't think so. ثانية واحدة. But may I ask what we have concluded in the first case? So the plan is to go for implantation?
I think what we will have to
Actually,
discuss it again.
Discuss it again.
actually, we have only limited images available for this presentation. Even the PET is not fully available. Only recorded video is available.
Mhm.
So with that, like Sir said, Dinesh sir said, we have to first go through the MRI and PET carefully. After that, only we can come to a conclusion. Without properly going through the images, going for invasive monitoring, we can't do that. First, let us go through the images and come to conclusion. That is the thing.
Okay, inshallah. Okay,
Because
so
even with the stereo, like cases like FCD, we tend to miss resection. Even with the stereo is not going to give us a 100% margin. FCDs, we can always miss. There is a tendency to miss entire lesion. So first, it's better to confirm the imaging rather than jumping to SEG. First, stick to the basics, and we will confirm with the images. Thank you.
yes, thank you so much. Okay, so our second case is another female who is 23 years old. She's left-handed and she's a university graduate with negative consanguinity and a positive family history of cutaneous hyperpigmented patches in her mother, with uneventful perinatal history and age-related developmental milestones with normal IQ. Her neurological examination is non-lateralizing, and general examination only showed these lesions. As we can see, there is axillary freckling and some hyperpigmented patches over her back, and the same lesions are present at her mother's skin also. Regarding her epilepsy history, the seizures started at the age of 14 years old, and she described, or we have recorded these seizure, the habitual seizure, which is only a single seizure type. The patient is describing an aura of déjà vu, but it's not consistent or persistent all through the seizures, and we couldn't capture this during the 5 ECTA recordings we attempted. This aura is then followed by behavioral arrest, which is always consistent. Behavioral arrest, oral automatism, bimanual distal automatism, followed by right hemifacial clonia. This can evolve to bilateral tonic-clonic, and sometimes this is followed by post-ictal dysphasia. But also, again, this is not consistent. Her seizure frequency is of twice per week, and she has tried multiple anti-seizure medications all through her history. And currently, she's still uncontrolled on adequate doses of levetiracetam and carbamazepine. This is her video showing the ictal semiology. This seizure occurred out of sleep. The patient aroused, and then she had very subtle smiling. No aura was reported by the patient for all the recorded seizures, which were 5. The patient stirred. Stirring was a little bit prolonged. And then this was followed by oro-alimentary automatism and subtle distal automatism. The arrest became more obvious, the behavioral arrest. And then, as we can appreciate here, her eyes locked to the right, and we can appreciate the occurrence of right hemifacial clonia with bilateral out-of-phase blinking being more prominent on the left, followed by clonic head deviation. And then this evolved to bilateral tonic-clonic. No post-ictal deficit was available. So to summarize, the seizure started by stirring, oro-alimentary automatism, right facial hemiclonic seizure, out-of-phase bilateral blinking being more faster on the left, clonic head deviation to the right, and this evolved to bilateral tonic-clonic. So from this video, we will ask sample questions, and I'm asking for your participation. What do you think about the déjà vu phenomena? Is it lateralizing to the right hemisphere or localizing to the mesial temporal structures, or it's non-localizing nor lateralizing? Kindly comment on the ball that appeared in the left side of the board, on the right side, sorry. Have we finished? Can we move to the next one? Can we see the results of the...
Yes, so we have 80% localizing to mesial temporal structures and 20% lateralizing to right hemisphere.
Perfect. It's the correct answer is B. It's localizing to the mesial temporal structures. Actually, mesial temporal loop epilepsy is all about auras. And one of the most common aura type in mesial temporal loop epilepsy is the déjà vu or the jamais vu or the reminiscence. It's not lateralizing, it's not very lateralizing, or it have a very low incidence of lateralization. Some literature reported that it might be lateralizing to the right, but this is of low evidence. So can we go to the next poll question? About your interpretation of this déjà vu phenomena. Is it an interpretive illusions? Is this true or false? You can start answering the poll.
Yeah, I have a technical problem, Spider, so can people please comment in the comment section?
Okay. Okay, déjà vu is an interpretive illusion. This is a true sentence. Déjà vu is in fact a state of highlighted consciousness where the patient has recollection of previous memory that he perceive as true. So the sentence is true. It's an interpretive illusions. This is the third question about the post-ictal dysphasia. Can we have the poll, or there is still ongoing?
The poll again. So.
Okay. So post-ictal dysphasia is lateralizing to the language dominant hemisphere. It's localizing to the perisylvian speech centers, or it's non-localizing nor lateralizing. You can answer in the chat section. Perfect. Post-ictal dysphasia is lateralizing actually to the language dominant hemisphere. It's not very localizing. Even this is the function of the fMRI for language. It lateralizes the language center rather than actually or truly or accurately localize where the speech centers are. So the correct answer is A. Post-ictal dysphasia is lateralizing to the language dominant hemisphere. The first one is about the value of unilateral blinking. Do you think it's lateralizing to the ipsilateral hemisphere, lateralizing to the contralateral hemisphere, or it's localizing to the posterior quadrant or occipital region, or it's of non-localizing or non-lateralizing value? Perfect, very good. It's lateralizing to the ipsilateral hemisphere. It's like a release phenomenon. And we have appreciated this unilateral blinking or out-of-phase blinking in this case and in the previous case presented by Dr. Ahmed Nassar. The fifth question from all of the above. Where is the most likely epileptogenic zone? How could you lateralize and localize this seizure semiology? Is it of left mesial temporal origin, left neocortical temporal origin, right temporal or right posterior quadrant temporal posterior quadrant origin, or it's a multifocal or bilateral independent? You can write down your thoughts. Perfect. Yes, as most of you have commented, it's likely arising from the left mesial temporal structures. Why the left? Because of the right hemiclonic facial, motoric, and neck involvement, and also because of the discrepancy in the blinking speed, where it's more appreciated on the left eye or more faster on the left eye. So it's left. In terms of lateralization, it's of left hemispherical origin. In terms of localization, the aura, the déjà vu, is likely to be arising more from the temporal, the mesial temporal structures, and also the behavioral arrest or the staring. This prolonged staring is likely to arise from the mesial temporal structures, and likely it's the very first appreciated or observable clinical phenomena in mesial temporal lobe epilepsy. So we can go through the EEG, and as we can appreciate here, that the background is showing right-sided attenuation. Her sleep structures were bilateral and symmetrical. Interictally, we have a lot of discharge. We have this left temporal sharp slow wave discharge, this left temporal spike and wave complexes. But we also had this right temporal spike and wave complexes, and this right LERDA activity, right posterior quadrant temporoparieto-occipital LERDA activity. So the interictal discharge is actually multifocal, and this was present in all the recordings. This is her ictal EEG, and we can appreciate that the ictal discharge this is this EEG in average montage, as we can appreciate here, and we can appreciate that the ictal onset is in F7, and we will see the EEG, the ictal EEG. This is the ictal video EEG. The patient was sleeping, and as we can appreciate here that the electrographic onset has started long before, almost 10 seconds before the clinical onset. So EEG first, and it evolves in terms of morphology and frequency and topography, but it started always on the left temporal derivations. Here, when the patient had the very initial clinical phenomena of behavioral arrest, oral automatism, the technician was testing her, but she's not responding. She wasn't responding. Her eyes are slightly deviated to the right, and then she have this manual automatism. Oroalimentary automatism. She's not responding to the technician. This is manipulative automatism, and then she developed this right facial hemiclonic seizures. And this is the second one. It's almost the same as the first one. Also, the electrographic onset has started much earlier before the clinical onset. And this is the seizure we have seen in the first place. This is the evolution of the ictal discharge. And then it's the same. This is the left temporal onset and the evolution.
No, if you can you please show the first EEG, I mean first ictal EEG, because that was clearer, so that we want to see where the ictal onset is, like
This
what
one?
you call an ictal onset. Yeah, yeah. Can you just show where you call what you call as ictal onset, which area?
Yes, it's F7, and it started in F7, and then T3 and T5 became involved.
Yeah, at the place where it started, where you say it is starting, can you go back and demonstrate where it is starting?
Here, this is fast activity, recruiting fast activity, and then it evolves to spike to rhythmic sharp waves, and then it evolved to sharp waves with spiky appearance, to rhythmic discharge with spiky appearance.
About T5, like between T5 and F7, which would you feel is more?
I think it started first in F7, and then a few seconds later, T3 and T5 were involved. I can go back. Here, there is fast activity here in F7, and then F and T3. Then it changed to sharp or spiky appearing waves, then rhythmic discharge with sharp contour. Then the frequency increased with evolution in frequency, and then it evolved T5, evolved in topography to T5, and then it became bilateral.
Sir, the T5 looks from the beginning more spiky than F7, no, sir? Like, is that significant, sir? Like,
Yeah, I mean, there's definitely early involvement of the entire chain. F7, T3, T5. So that is there. That is there. And he also showed that there are interictal discharges very nicely seen in anterior temporal, but it's also seen, you showed in the posterior region also. That's a bit odd for a pure mesial temporal.
Yes.
We must think of either pseudotemporal or temporal plus,
Temporal
even though
plus.
this,
Yes.
although the seizure type is purely temporal and everything is fitting into a mesial temporal without a doubt, but there are two things. One is that you don't expect posterior temporo-occipital spikes in a pure anteromesial basal temporal epilepsy. That's the first thing. The second thing is, I don't know what percentage of seizures where she develops right facial clonic jerking, which means that it is spreading to the perisylvian region. But of course, it's spreading a little late. But is it every seizure that she gets those facial clonic jerking?
No, sir. No. This
Yeah.
only occurs
Yeah.
upon anti-seizure medication withdrawal when we recruit.
Yeah, I think, yeah, I agree with you. I think so that I won't consider as anything different. So that's fine. But the two things that concern me a little bit for a pure anteromesio-basal, if it was a pure mesial temporal epilepsy, I don't think you will be presenting it here now. So that means
sir,
it's something more than that.
sir,
So,
that day at the beginning, and Arun also pointed out, like, the EEG onset was much earlier before the clinical onset.
Clinical onset, yeah, that's a very good point.
With that, I mean, that way will
see,
That is so.
EEG onset happening before the clinical onset can happen. Not a problem. You get electrographic seizures without any clinical. So that's not a major problem. The major problem here is that the early involvement, right at the beginning itself, there's an involvement not only of the F7, but also of T3 and T5. That's one. Interictally also, you saw more posterior discharges, which you nicely demonstrated. These 2 points would tell that, well, it's not purely mesial temporal epilepsy. The seizure type is clearly mesial temporal without a doubt. Whether its origin is actually in the mesial temporal or it's coming from somewhere else and then entering the mesial temporal and presenting as mesial temporal epilepsy. That is what we have to see. So from that point of view, we have to be very careful here. You should not be I mean, you should not be excited by seeing something only in the mesial temporal. You'll have to see whether there's something in the extratemporal structures like posterior temporal or temporo-occipital, occipital itself. So that's something that we have to keep in mind. This will be my take on this because of those spikes, which are interictal spikes, which are more posterior. You showed those.
Yes, sir.
Sir, when
Yes, sir. Even the
Ahmed presented, there was a background asymmetry also. The right was, I think,
background.
slow.
No, this is from the left side, isn't it?
Yes, sir. The background is
Yeah,
Yes, sir.
on the right side, and the interictals
on the left side,
quadrant is on the right side.
Background flowing is there, sir. Bihemispheric pathology is there. In that, all the seizures are recorded from left hemisphere. Background
what is the evidence
asymmetry.
of bihemispheric? What is the evidence of bihemispheric?
Because IEDs are present on both the hemispheres, sir, and even the background flowing is more
No,
predominant
IEDs
in.
are on both sides, is it? It's not on one side alone.
Yes, sir, on both sides. And
Both sides
background
where? Which
abnormality
IEDs
is more.
No.
You are asking about the blinking? The blinking is bilateral?
No. Interictal discharges are bilateral, eh?
Bilateral, yes, they are bilateral. Bilateral temporal and temporo-occipital.
in the
Yeah.
Right
So
temporo-occipital, yeah. Yeah.
Okay.
And predominantly
Showing.
right temporo-occipital, background slowing also more prominent over the right side, sir.
Okay. Got it.
And all the seizures which are recorded are from the left side, left hemisphere.
Yeah.
Yes.
So there are 5
Yes.
seizures.
And
All
the
of them
background
came.
is attenuated.
Okay. Got it. Okay. So this is quite a complex epilepsy.
Yes, this is true, and this is a very good discussion of the showing how temporal loop, mesial temporal loop epilepsy could be misleading. You have
Absolutely.
clearly and beautifully highlighted what are the pitfalls in this, or the red flags against a pure mesial temporal loop epilepsy in this particular patient, and this is very good.
It is very beautifully demonstrated. Yes, and discussed.
Thank you.
Yes, sir. We also concluded it's either a temporal plus or pseudotemporal presenting as temporal.
Yeah.
Yes, totally agree.
On the left side, even though bilateral pathology is there, even it's mostly now left hemispheric.
Yes, and you recorded 5 seizures. All of them were the same.
All of them are the same. Yes,
Yeah,
we recorded 5 ones. All of them are the same.
So the chances of the 6th one coming from the opposite side is very low. That's what it is. Yeah, that's what it is. I mean, if you record 5 and all 5 are on from one side, the chances of the 6th one coming from the opposite side is very low.
It's very low. Yes, totally agree.
Good.
So to conclude, we regarding the lateralization, all the seizures are coming from the left hemisphere. Regarding the localization, the initial impression was that the seizures are of mesial temporal loop origin, but after viewing the EEG, the ictal and the interictal, temporal loop plus or pseudotemporal, as you clearly illustrated, should be suspected. Also, the involvement of the contralateral hemisphere could be suspected based on the presence of right background attenuation and the multifocal interictal discharge. This is her neuropsychological evaluation, and she had mildly impaired verbal memory, executive functions, and social cognition.
So this is generalizing to the left side, isn't it?
Yeah. The mildly impaired verbal fluency is lateralizing to the left. And verbal
for a bilateral disorder, her IQ is quite good, very good actually. I mean, 101, and even her performance IQ is better than to the left hemisphere. So you have at least 3 concordant data to suggest that the left hemisphere is involved more. Yeah.
Yes. The clinical, the ictal EEG, and the neuropsychology are lateralizing to the left hemisphere.
Yes.
The interictal, the background, are of doubt of right hemispherical.
Very nice. Yeah, that's nicely summarized. Yes.
Okay, so this is her MRI. We performed a 3 Tesla epilepsy protocol MRI, and this is a video. And this is the surprise. The lesion is actually appreciated on the left temporal parieto-occipital, where we can appreciate the presence of gray white matter clearing.
Right side.
Right, to the right side. It's here.
Yeah.
Mesial temporal, entorhinal, and parahippocampal, and even the posterior, the parieto. Yeah, it's right. It's absolutely right on the MRI. This is a 3 Tesla MRI.
Yeah, it is right on of the MRI, right on the MRI. It's
right on the MRI.
And it's right. It's perfect. And that also shows the background abnormality. That is the reason, because fairly a largish area. And,
it's a very large area to explain the background attenuation in the right hemisphere.
And the whole the temporal-occipital region itself is abnormal, completely abnormal.
Yes,
the entire occipital, and it's not just confined to just it's an extensive very clear from the, you see the gray white abnormality right from the back to the front.
Yes, sir. From the
Yes.
occipital all the way back, all the way
In fact,
front.
the entire occipito, this is an occipito-temporal extensive dysplasia.
Yes.
That's
Right.
what it is. That's why it's falsely lateralizing to the other side and all that. And
The ictal
of course,
EG
it's
is falsely
optical.
lateralizing to the left hemisphere, and the neuropsychology.
It is seen. It is, but you also said that he's. Yeah. Okay. So he's this. She's a left-hander. You said, but
She's a left-handed, yeah.
that's a bit.
She writes with the left, but she can manipulate things with both hands. But she writes. She's left-handed.
So this is a extensive temporo-occipital dysplasia
On the right hemisphere.
of the right hemisphere. Yes. Yes. Is the parietal spared?
It's affected. I think
Parietal.
it's affected.
Is it
Sir,
limited
can
to the?
it be a
No.
dual pathology? One, either its right side is silent and left is producing things, seizures, or due to the right pathology, the seizure is coming from the left, like wasted hippocampus, like that.
I think something like that. Yes. I think
Yeah.
because you're seeing background which is attenuated and also slow, isn't it? On the right side.
On the right side.
Mm.
Yeah.
Somehow it doesn't seem to be generating too much of abnormality. That's the thing. Yeah, I agree. It's a good point. Can you just show the previous slide? Oh, this is the slide. Is it? Yeah. Okay. Yeah, this one. Yeah. Okay. Okay. Yeah, please move on. Yeah. Thank you.
This is the PET, and the PET is bilateral actually. It's bilateral, but it's more on the left. Oh, no, more on the right, but it's bilateral.
Yeah.
Bilateral temporal hypometabolism.
Yeah. Yes, very interesting. Extremely interesting case. Extremely interesting. This is a real googly, actually. It's very good, very nicely put. And it's truly a bilateral disease. I mean, there is no doubt about it. Whether it's truly bilateral or is it falsely lateralized, is it truly unilateral with a completely false lateralization to the other side? That is what we'll have to prove. So
Yes.
there is bilaterality out. Whether it's truly bilateral. If you look at the structural abnormality is clearly lateralized to right. Whether there's subtle structural abnormality on the opposite side, very difficult to know. But absolutely abnormal temporo-occipital extensive dysplasia, the whole of the occipital and the whole of the temporal. So that there's
MRI
no
wise, we didn't find anything on the left, sir.
correct. But
yeah, we couldn't appreciate anything in the structural MRI, just in the PET.
Yeah.
There was bilateral temporal hypometabolism.
Yeah. So it's very clearly it's from structurally it's on the right. Now you have to prove that the right is the driver of the left.
Yeah.
Or
the right is there is
silent.
something. Yeah.
Right is
which
silent.
of which?
And the left is the culprit.
Yes.
The left is just independently or on its own generating all the seizures. The right is just a structural bystander, nothing else. Or the right is the completely abnormal area, but since it's not able to really, it is spreading to the other side because of the abnormal connections that can happen with this kind of dysplasias, going to the normal side and then manifesting as a the opposite side seizure, when the actual abnormality or actual seizure origin is from the right, but it is spreading to the left and manifesting entirely as a left temporal. This has to be proved. So that is what we'll have to do. So that's an interesting point. So So what have you done? What are you going to do? This is my
bilateral implantation.
Yeah, I think you should.
Bilateral occipital, temporal, and parietal, sir. Implantation.
Yeah, this will require it.
And
Yeah.
also implanting the lesion in the temporal lobe little more on the right side, so that we have sampled the lesions adequately. At the same time, wherever possible, to be symmetric in bilateral occipital, bilateral parietal, and bilateral
Yeah.
temporal.
Agreed.
So that way we
Yeah.
can have a good coverage.
Yeah.
That day in Ahmad said in left there is amygdala enlargement of the amygdala left side.
Yes.
In MRI, can you show
MRI.
that?
On
Vince,
the-
that day, yeah, I remember. Yes, correct, Arun, what you're saying. That day, that I think was there. One doubt was there.
I don't think the left will be entirely normal, is what I think. But
Yes, sir. On the left temporal, the amygdala, actually, Dr. Michael reported that there's an enlargement on the left amygdala.
it could be. I mean, that is the right side we are showing, but where's the left amygdala? Can you just show?
If you want, I can show you the actual.
Do you have a left sag or left coronal? Do you have?
I have
The
I
coronal
think
image for this
I think
compare the
Dr.
left.
Ahmed can share can you share the DICOM link? Yeah.
Yes, I'll share it. 1 second, please.
Also take in mind that the patient might be having a neurocutaneous disorder because of these skin lesions
That's
in
a
her
very
and her
important
mother.
point. That's an excellent point. Is this some kind of it's definitely a neurocutaneous disorder with with a is it with an extensive temporooccipital dysplasia? There's absolutely no doubt. What about the ventricle on that side? Is it equal? Is the occipital horn? Yeah. Okay, go on. Yeah, it's clearly abnormal there. You can see the mesial, that is the parahippocampal gyrus, is absolutely abnormal. And here also the lateral posterior. Yeah, it's a posterior cortex. Yeah, it's clearly abnormal. Yeah.
Would you like to see it out there also?
So the insula also I felt was little abnormal, sir. Like when we see the in the coronal, as we go posterior, we see something like a thickened insula.
On the left,
Can you
play
the
back?
right side insula only?
They were asking about the insula on the right side.
The T1, can you please show?
T1, okay.
T1. Yeah, just slowly go down to around the insula. So I just want to show this. So those areas of thickening, can you just?
That's very anterior.
Yes, sir. And the similar lines as we keep going behind.
حبيبة هي بتضرب الشروط وبتضرب
So
الشروط
this area.
وبتضرب
Yeah.
May I ask you to mute your mics, please, apart from the speakers?
You want me to go more posterior or?
Sorry?
You want me to go anterior again?
No. I think it's okay. I think. Yeah, I think it's quite clear. So I mean, this is the plan. This is the only way you can explain this whole thing.
So it's very clear on coronal and T2. Actually, you can really appreciate this.
Yeah, that is clearly abnormal. That's on the right side. The whole thing is on the right side. Whether the left is subtly abnormal. At least it's not seen. Anyway, whatever be the thing, I think we have to implant and explain one of the two hypotheses. That is, the right is clearly abnormal, no doubt. But whether that abnormality is silent and the actual culprit is only on the left side, or it is the right is feeding the left. These are the two hypotheses, and the management depends entirely on that. So, yeah, that's the only way. You cannot go without a bilateral implantation.
Yes, totally agree.
Yeah, that's the way forward, I think. Yeah.
So what about the plan of implantation?
Yeah, I mean, this would be a temporo-occipital implantation. I don't think the parietal, but I think you need to put, just the parietal also should be covered a little bit because, about anterior to the parieto-occipital sulcus, the precuneus has to be covered, and not more than that. I don't think anything more than that. And the posterior cingulate. And that should be on both sides. And then, yeah, I mean, the occipital 4, that is 4 or at minimum, that is anterior superior occipital, anterior inferior occipital. I don't think you need to have posterior superior and posterior inferior occipital. So that is for sure. So 4 electrodes for that, and then posterior basal temporal, anterior basal temporal, hippocampus, amygdala, and maybe the insula, and then the other side. That's all the same thing almost. So I think it's a bilateral, almost symmetrical implantation with a clear hypothesis to prove that one of the two hypotheses is that the right is feeding the left. Number 2, the right is just structurally abnormal, but functionally just nothing. And the left is truly the only epileptogenic structure. These are the only two hypotheses. And worse comes to worse, the third thing is there are electrographic abnormalities going on the right side, and 2 clinico-electrographic on the left side. Now, that would be a nightmare because then it's truly bilateral. Both. So these are the 3 possibilities. So we have to be prepared for any of these.
Sir, what about frontal, sir? Fronto-opercular spread. Since
What? No, that's very
frontal coverage, no need.
No, I don't think. I mean, I don't think we need to really because even if the frontal is involved, it's involved, much later. So I don't think we should be wasting much electrodes into the frontal region. I don't think it is.
Yeah, yes, sir. Just to make sure the coverage.
That could be
Yeah,
the
last
second or the third.
just where to put in frontal. That's my
I
question.
don't think.
Predominantly.
I think between the frontal and the parietal, I would cover the parietal much better.
Yes, sir.
And I would
And
probably
insula?
put in a perisylvian insula, that is an insular coverage through the perisylvian. No, that's it.
Clinically, it was temporo-opercular like that only, mostly like and posterior temporal, basal temporal like that, because of that facial jerking and
facial jerking comes
prolonged.
much later. You see,
yes, sir. Yes, sir.
It's a long, the facial jerking has come after several seconds.
Yes, sir. Last spread only.
So that means it's not truly a neocortical, and then that's the reason why I asked the question. Is every seizure having the facial clonic jerky? And he said no, because of medication withdrawal. Correct? That's what, if I'm given to understand.
Yeah.
So I think it's not a temporal neocortical epilepsy, and so therefore, which then very rapidly every time spreads to the perisylvian region. That's what I was trying to ask. And so we are dealing with a mesial temporal, And when you look at the occipital, then the occipital is going into the temporal. So this is an occipito-temporal epilepsy.
Okay.
It's an occipito-temporal epilepsy.
Yeah, sir.
And therefore it is going through the inferior, that is the occipito-temporal pathway and not the occipito-frontal pathway. So that is very clear. The seizure is clearly mesial temporal. Only then it goes into the perisylvian. If it was lateral temporal, it would go to the perisylvian every time. So these are the reasons why we think it is only like that.
Okay.
May I have some questions for you, sir?
Yeah.
What about
Sure.
the auras? The patient is describing this deja vu very frequently, but it's not always present in all her seizures.
What is the aura?
Should we
What aura?
the deja vu?
Oh yeah, the
Deja
deja vu. Yeah, the deja vu is a mesial temporal. I was more
Yes.
interested in knowing whether, you can just again interview the patient and then see whether by any chance does she get sometimes some form of a visual kind of a illusion or something like that. Part of the
No, sir. I asked her
deja vu
I
kind
don't
of
think, yeah.
visual aura many
memory
times, and
problem
she always
or
denied
is
it.
a visual phenomenon. That's what I want to know. My question is, what is the deja vu? What is the experience that she recalls? Is it a visual scene that she recalls, or is it a memory that she recalls? What is it?
Her exact words was that she
Vivid? Is it a vivid scene? Is a vivid scene, or is it a vivid experience in the sense that something being told to her? Sometimes these people will tell, especially if it's the posterior cortex. I mean, they would say that I can, I'm, a very familiar building I'm seeing. Same building comes in my memory just before the seizure. That's a deja vu, but that's a visual deja vu. And so it goes at the back. So
Yeah,
the
we
deja vu.
asked her many times about the aura very specifically, and she said that she does not see anything, she does not hear anything. It is always that sense of familiarity that she just feels that this happened before.
That's good. Already very good. So that puts it squarely and purely into the mesial temporal, and that's very good. That's excellent. I mean, these are the points that we have to be careful about, and that's very good. She doesn't get any other type of aura. There's no multiple auras, isn't it?
No, sir.
Yes, sir.
only the
No,
deja
no.
vu.
And what percentage of seizures have the auras? That's another thing. Out of 10 seizures, how many will have an aura?
This was
That's
exactly
another thing to explore.
saying that we recorded 5 seizures, and in none of these seizures she had an aura. Although she reports having an aura, but we never recorded this deja vu in the EMU.
So the point is, that means that's another very important point that you'll have to ask now to yourselves, to ourselves, I would put, is have we recorded all her habitual seizures? That's a very, very important. If you have said that she's experiencing aura, and then none of your seizures have had an aura, that means she's having 2 seizure types. I would assume that, and especially in the current context of having seen 2. I mean, this is bilateral, obviously. I'm now doubting whether you have actually recorded. Now, I don't know whether that aura seizure would be different from the seizures that you have recorded. So my job would be to interview this patient and ask her during the video EG, what are these types? Are these the same things that you would normally get, or are these slightly different? This is my first question. In other words, are we dealing with true bilaterality, where one seizure type is the aura followed by the mesial temporal, or the other one without aura and mesial temporal? That without aura and mesial temporal may be coming from the left side, and the aura with the mesial temporal may be coming from the right side. So I would go all out to record more seizures I will interview the patient first and ask her to draw the number of seizures that have aura, the number of seizures that do not have aura. She and her, witnesses, and then make every attempt. If she says that, yeah, and those during that video EG, I never got that aura, which means that you're not recorded all the seizure types. So that becomes a very serious issue. So we'll have to, before we embark on this major implantation strategy, I would first thing is to bring back this patient, interview her again, confirm that this is the only seizure type. If it was the only seizure type, then why didn't I record those auras? I'm very seriously now doubting that. I'm now seriously thinking about whether she is actually having two seizure types, both are mesial temporal. One is with aura, one is without aura. And if I go with that hypothesis, I have now recorded only one type of seizure, which is the seizure without aura. This is how I'll approach this case. Before I implant, I want to know, I will be satisfied only if I record on the scalp a seizure with aura. I'll be satisfied. And if you show that this seizure with aura is also coming from the left side, then again these three phenomena that we have now we have discussed till now will remain. Otherwise, right from the beginning, this becomes a bilateral epilepsy. You get the point?
Yeah.
Yes.
Mm.
And
Yes, sir.
then
Another thing.
so
Yeah.
you see how many subtleties are there in these things. You've got to be very, very, very careful. And again, it's all only history.
Yeah.
Have you seen
Yeah.
that we?
Yes.
Understood.
We have to be
Yes,
very
sir.
obsessed.
Oh.
Arun, what
Yes,
is
sir.
saying?
Like this.
Dr. Alshima asked, like, why in some of the
So if you
seizures
discuss
aura is
whether
coming. Sometimes the symptomatogenic zone seizure might be spreading from a asymptomatic area, like silent areas like precuneus where there won't be any aura. Some of the time, the aura may be recruited from the
no,
symptomatogenic.
all that is theoretical. I want to know.
Yes, sir.
All that is theory.
Yeah, yes, sir.
I want to
Yeah, sir.
record.
Your
I want
point.
to ask
Yes,
the
sir.
patient first whether we have recorded all her seizure types. That is my
Yes,
first
sir. That
job.
is.
And if she says, no, I think I'm getting another type also where there's an aura. First of all, I want to know out of 10 seizures, how many seizures have an aura? That's my
Yes, sir.
first job.
That is a must. Yeah, yes, sir. That is a must, sir.
Thing is,
Just I'm giving
I will,
explanation
I
to
will, I
what she
will
asked.
now get this patient inside and record. And with this information, I would like to record at least one seizure with the aura and prove that either that seizure with the aura is also the same as what you have already recorded, or it is a different type. Your treatment strategy or your implantation will be completely different. Now, if it is indeed the aura seizure is coming from the right side, you're dealing already with a truly bilateral disease. Here, what we are assuming is, although there is a bilateral disease, one structural, other functional, we think it's unilateral, manifesting as with a false lateralization. That is our presumption, and that's what we are trying to prove. But then, if on the scalp itself, if you have shown that it's truly bilateral, then I don't know what, then we'll have to, then our exercise will be completely different. What is the percentage of bilaterality? You could still go on. You get the point. See how many questions you have to answer. So let us now, I think you please get this patient back, ask her these questions, try to record at least one seizure with the aura. That would be very, very helpful. It would probably alter the course of how we discuss. I mean, this discussion is very good, but you have to only prove that the aura seizure is also coming from the left side. If that is the case, that's the best case scenario. But if the aura seizure is actually indeed coming from the right side, well, then our questions are going to be different. Our approach is going to be the same, but our questions are going to be different. Because in that case, then you'll have to record during stereo EEG. I will still do it. I will still do it. We were just, that's the reason why when we started from the beginning itself, we said that how many, we recorded 5 seizures. The chances of the 6th seizure coming from the opposite side is low. But then you'll have to prove it now. And then when you actually see that this is bilateral, actually, assuming that it is bilateral, the aura seizure is coming from the right side, and then you go in with the implantation, and your question that you're going to answer there is only the degree of bilaterality, not the first 2 hypotheses that everything is coming, one side is silent, the other side is abnormal, or this side everything is starting on the right but is manifesting entirely as left. Those things are gone out of the window. Then you'll have to record 10 seizures and see how many are. Then you're answering bilaterality. Okay, if there are 9 seizures coming from one side and 1 seizure coming from the other side, well, you can still go ahead with that side. But if 5 seizures are coming from one side and 5 seizures are coming from the other side, well, this patient is going to have a kind of a, maybe DBS or something like that.
Mhm.
So
the
please
role
bring
of
this patient. Please bring this patient into the monitoring
Sir,
room.
this is because of with the fact that we did not record the aura. This patient is actually in the EMU now, and we've been trying to record seizures for 3 days now to capture this aura, because we
Yeah.
as you correctly stated, we will not be very happy unless we record this.
Absolutely. Please do that.
Yes.
If you get the aura and prove that that seizure also has the same electro-clinical characteristic of what you have already shown of the other 5, I'll be happy. Not a problem. All of us will be happy.
Yes.
Hopefully the aura will have an electrical correlate, not
It should
as the
show the
previous one.
same electrical signature as the other 5. Then I will accept that seizure is also the same as the other 5. If it has different electroclinical characteristic, then our job is a little more complex, right?
So also, the other comment is that she does not get aura when we taper anti-seizure medications, and I think this could be explainable maybe of the very fast spread. But we will try to record another seizure without tapering the anti-seizure medications and see how things happen.
Good, very good. See, so you've gone into all these details, excellent. But I think we should somehow, you should make an attempt to record one aura seizure. Maybe give us the medication and then press her out or something like that, get the aura.
Yes.
And during the implantation also, if we proceeded to implantation, we should have this aura and the post-ictal dysphagia recorded also.
If you see, if we indeed show that the aura seizure is coming from the right side, truly coming from the right side, then no, you have no choice but to record 10 seizures.
10 seizures.
And then see the percentage. If those 10 seizures, all of them were without aura, that means, and then everything is, coming from the left side or whatever it is, one seizure type, that means that seizure type is dominant, and then you can go ahead and do whatever we want to do. So whatever it is, let's now first record the seizure, then we'll decide. It's good.
This has become like Arabian Nights. I mean, only from the next week we will know what we are going to do for this patient, because now we are again recording this, and the participants will get to know it only next week, actually, what is that we're going to do for this patient.
Yeah. Yeah, correct. Very good. Excellent.
And should we have fMRI for the patient, fMRI language for the patient to lateralize the language dominant hemisphere, as she's left-handed?
See, this is clearly bilateral, and that's so we'll have to the only test at the moment that we have to concentrate now is to record that particular seizure. And then you do the other things like fMRI and all those things, but ultimately that particular seizure type has to be recorded.
Okay. Inshallah. Hopefully, inshallah, we will
Yeah.
feed you back next week or the week
So,
after, inshallah.
thank you, Dr. Shaima. And on behalf of the organizing committee, I want to thank everyone for a very productive first MDT. And my special thanks to Professor Danish and Professor Natation and Professor Arun for their
Thank
time and
you.
expertise and generous mentorship. Thank you so much, sir. And we are very happy to have you in November. So thank you so
Yeah.
much.
Thank you.
And
Thank you.
look forward to seeing you at the next meeting and continuing this important work together.
Thank you. Thank
Next
you.
meeting will be the next Friday, same time, right?
Same time, yes.
Inshallah.
Okay. Thank you.
Next Friday.
Thank you. Thank you, Professor Danish.
Thank you, sir.
It's very
Okay.
interesting.
Thank
Yeah.
Yeah.
Thank
Bye
you,
bye.
everyone.
Thank you so
Thank
much.
you.
Thank
Thank
you. Thank you, everyone.
Thank you so much.
Assalamu alaikum.
سريعا كده احنا ان شاء الله this is the Indo Egyptian Stereotactic Epilepsy Surgery Week. طبعا حضراتكم عارفين ان احنا بنعمل pre-surgical evaluation to the cases عشان خاطر نضمن a good surgical outcome in epilepsy surgery. وفي معظم الاحوال البيشنتس بيكونوا concordant والبيشنتس بيكونوا يعني مش محتاجين any further investigations. يعني ايه؟ يعني احنا والله دلوقتي مثلا patient عنده left temporal semiology والام ار اي بتاعه في الليفت هيبوكامبال سكليروزز والاي جي طلع ليفت يعني temporal. فالبيشنت ده ستريت فورورد مش محتاج اي تفاصيل تانية يعني فوي بروسيد على طول تو سيرجري. لكن احيانا القصه بتبقاش كده زي في الكيسز اللي احنا هنعرضها النهارده. احيانا الموضوع بيحتاج ان احنا محتاجين تفاصيل اكتر. لا البيشنت عندها ليجن في حته والاي جي طالع في حته ديسكوردنت بيشنت او البيشنت ام ار اي نيجاتيف. ففي الكيسز دي بنحتاج اس اي جي. وطبعا الاس اي جي يعني ليه تكنيكال اوبستكلز كتيره جدا. احنا بقالنا فتره طويله احنا ودكاتره كتير من زمايلنا اللي بيحاولوا ان هم يعملوا اس اي جي في مصر. لكن للاسف كان في اوبستكلز كتيره والحمد لله بفضل تعاون يعني جامعات كتيره ومالتي ديسيبلينري تيمز الحمد لله ان شاء الله ده it would be possible يعني باذن الله لو ربنا اكرمنا وقدرنا ان احنا نكمل الاس اي جي باذن الله. ده يكون الفيرست ستيب ليه. سريعا كده البروجرام هيبدا ان شاء الله. احنا النهارده يعتبر ده اول يعني جزء في البروجرام. احنا عندنا 3 اونلاين ميتينجز. اول واحد النهارده ان شاء الله وبعد كده الجمعه الجايه والجمعه اللي بعديها باذن الله هنناقش الحالات مع الدكاتره. وبعد كده ان شاء الله الامبلانتيشن هيبقى يوم 24 نوفمبر. ده هيكون اليوم اللي احنا هنزرع فيه البيشنت اللي احنا هنختاره من الكيس ديسكشنز دي. يوم الاثنين هيكون العمليات دي هتبقى لايف على زوم وهيكون في ديسكشن اونلاين برضو. وفي نفس اليوم هيكون في الهايبوثالاميك هامارتوما الار اف ابليشن بتاعت البيشنت. ده هيكون يوم الاثنين. يوم الثلاث ده النيورو كريتيكال كير فور ابليبسي سيرجري. ده هيكون ورك شوب خاص بالدكاتره الانترست ان هم يشوفوا ايه اللي بيحصل في الرعايه بعد ما البيشنت يطلع. يعني ايه نون كونفولسيف سيس ابليبتيكس يعني ايه سيس ابليبتيكس وكل التفاصيل دي باذن الله. بعدين بقى المين كور بتاع البرنامج اللي هو هيكون يوم الخميس والجمعه. ده هيكون في الاميره فاطمه باذن الله. ده الاس اي جي ورك شوب خلاص هيبقى على يومين. ده بقى هيكون فيه يعني هنمشي فيه الجيرني كلها من اول شكل السيجرز والسيميولوجي وهتكون معموله في عباره عن زي ورك شوبس ان سمول جروبس عشان خاطر يكون فيها اكبر استفاده. هنمشي الهول جيرني بقى سيميولوجي اي اي جي الام ار اي الايمجنج. بعد كده ازاي بنعمل اناتومو الكترو كلينيكال كورليشن وازاي بنحط بلان للاس اي جي. فايت ويل بي يعني كويسه حتى لو حد يعني عنده فيري بيسك اندرستاندينج والاكسبرتس برضه ان شاء الله هيستفيدوا كتير. يوم السبت ده ان شاء الله هيكون اليوم اللي احنا هنشتغل فيه العمليه اللي احنا للبيشنت اللي احنا زرعناه اول يوم باذن الله. فده ان شاء الله هيكون يوم السبت وهيكون برضه في الاميره فاطمه. لو اي حد من الدكاتره عنده اي اسئله، هو النهارده ان شاء الله اليوم هيمشي ازاي. احنا اول حاجه دكتور احمد نصار هيعرض اول بيشنت، وبعدين دكتوره شيماء هتعرض البيشنت الثاني. بعد كل يعني برزنتيشن الدكاتره دكتور دينش ودكتور نوتيشن الاثنين هيكومنتوا، وبعدين دكتور علاء رشاد ان شاء الله. ولو اي حد من الدكاتره عنده اي اسئله استاذنكم بس يحطها على الجروب وانا هقراها ليهم وان شاء الله نبدا. Okay, Dr. Natation is here, right? Okay, we are waiting for Dr. Danish.
Yeah, I'm here, and Arun and Dr.
Okay. So okay. So good evening, everyone, and welcome to our first MDT meeting in the run-up to the Indo Egyptian SEEG week. It is my very great pleasure to introduce and thank our two guest faculty who make this program possible. The three faculty, of course. So first is Professor Danish Nayak, a world-class epileptologist whose team has performed hundreds of SEEG cases and who has been mentoring our group from the start. And with him, of course, Professor Natation, an experienced functional neurosurgeon, and who has visited Egypt twice, and through his technical leadership, who will guide our implantation and intraoperative work. And also Dr. Arun, who is an epileptologist, also from India. So we welcome three of you, and we are deeply grateful for all of you for traveling this long distance in November, and for sharing your time and expertise, and of course for committing to this live SEEG implantation in Cairo. Your mentorship is the most important factor in safely launching SEEG in Egypt, and of course making our training and our national teams possible. So thank you, professors, for your partnership,